Our next talk is from Dr. Sarah Edwards. Sarah is a consultant in emergency medicine and paediatric emergency medicine, and she works in the University Hospital of Wales in Cardiff, and she's going to give us a talk on paediatric stroke. Sarah, are you all right there with your slides?
Yeah.
And
can you hear me?
Yes, we can.
Yeah, fantastic. Yeah, good morning, everybody, and thanks for having me. So my name's Sarah Edwards. Yeah, like Hannah said, I'm one of the paediatric emergency consultants based at UHW. This morning, I've been asked to talk to you about paediatric stroke. And I think first and foremost, just to manage expectations, I am not a paediatric neurologist. I'm a paediatric emergency consultant. And I think this talk, the aim of this talk basically is to try and go through some of the kind of practical managements of paediatric stroke on the basis that we recently had a case that I think highlighted a lot of really important learning issues. So, you know, just so you can anticipate what this talk is about, it's not about kind of different kind of stroke patterns, stroke mimics. This is very much a kind of practical approach to kind of stroke management, and also kind of looking at that case and drawing all the important learning that we got from it as a team, that I think actually would be beneficial for other centres just to think about their local setup and how they would manage it. So kind of paediatric stroke kind of over the last few years has had much more publicity, both in the kind of, we're in the public and as a kind of a professional body, we are much more aware of paediatric stroke. Despite there being a lot of increased awareness about stroke, it still amazes me that we have kind of nursing and medical colleagues that are astounded when they hear that children can have strokes. It's very much assumed to be an adult problem, and I think there's still a lot to be done with regards to educating kind of all kind of allied health about kind of paediatric strokes. So I know I'm talking to a lot of trainees that are doing paediatric emergency medicine, and I'm sure wherever you work, you've probably seen this kind of poster, which is based on the RCPCH 2017 stroke guidelines. Okay, I think this is a really useful poster, and certainly we've got a copy in our department, but I think, you know, reflecting on the case we had a few months ago, there's a lot of assumptions, and I think what this guideline does beautifully is it simplifies the whole process, which we'll go into the case we had recently, which is often not how these children present. You know, on this kind of stroke poster, there's a huge assumption that you get a pre-alert, that you've got time to prepare, that, you know, that you've got kind of all your resources in emergency ready to go. And we know that children don't present like this. Okay, so we'll kind of go on to the case that we had. So like every challenging case, it always happens on a Sunday afternoon or out of hours. So a 3-year-old boy presents with his parents with a very vague history of being unwell for the last 48 hours. Pretty non-specific history. They were just kind of, he'd had 2 episodes of vomiting, and that seemed to be getting better. They'd put him to bed the night before, and they actually thought he was much better. And then next morning he woke up, he was kind of bright. He'd asked for the windows, the blinds to be opened, and they'd gone downstairs to watch TV. Whilst watching the TV, the dad thought that the little boy was giving him a cheeky grin. But then on closer inspection, he felt that the left side of the face definitely had a droop, and that he had kind of maybe some slurred speech. But on pressing this family, it was very hard to ascertain whether this child had spoken at all since the incident. So kind of he was seen in triage. He was a kind of a bright, alert boy. He was moving kind of arms, limbs. He was noted to be quiet, but then he was 3, and the parents kind of said, well, it's not that unusual that he's slightly shy around other adults. And the left-sided droop was very subtle, and I'm not sure if it was actually appreciated initially in triage. And he was triaged as a category 4 patient. So I think just from that history, one of the first learning points for us is kind of education of triage and nursing staff. You know, this boy was given a triage 4, which meant that he could have waited much longer to have been assessed, whereas any acute neurology should be given a triage 2. But again, I think this case highlights how subtle his presentation initially was. And I suppose when we kind of do paediatric emergency medicine, lots of the facial droops are put down to a Bell's palsy, and it's kind of differentiating kind of an upper motor neuron lesion from a lower motor neuron lesion, which can be very difficult in a 3-year-old that's not going to be completely cooperative with your kind of examination. So I think that was one of the first learning points, and we haven't even got to the assessment of the patient yet. So I think there's 7 that I kind of want to focus on. So medical assessment, he was reviewed by a senior registrar at approximately 1:30, so 3 hours after the onset of this kind of facial droop that was noted by the father. And the senior registrar was very astute and noticed that there was sparing of the forehead. And this wasn't consistent with a lower motor neuron lesion, and this was more suggestive of an upper motor neuron lesion. However, it was very subtle. And when you kind of spoke to this young boy, you know, with assessing other neurology, he was moving his arms, moving his limbs. He did have a preference for the right limb. You know, on popping bubbles, he would kind of do it with the right arm, but could do it with the left, but he would prefer to do it with the right. He was walking, he walked with me up and down the corridor, and he seemed to understand everything that I asked him to do from a kind of following commands, but certainly we could not get this boy to kind of talk at all. He's from a bilingual family, so they spoke Welsh and English at home, and even in both languages would not kind of talk to either the parents or myself and the registrar involved. So then we had the task of trying to assess his neurology. And I'm not sure how many people have used this scoring system for stroke in the context of a 3-year-old, but I think it's really challenging. With regards to level of consciousness, he was alert. With regards to kind of questioning about, you know, whether he was orientated and his name, he wasn't able to do that. But then I suppose lots of 3-year-olds might not be able to do that. He would kind of follow commands. It was very hard to assess his whether he had any visual field deficits. He didn't appear to have any gaze palsies. He was noted to have a partial paralysis of the left side, so he scored a 2 for that. The motor findings in the upper limbs were very subtle and quite hard to score. And then with regards to kind of limb ataxia and best language, we scored him as having severe aphasia in the context that, you know, he would not talk to us at all. So we scored him as a 4. But again, I think it was really difficult to perform this kind of neurological assessment on such a young child. So kind of the learning point 2 is to kind of be familiar with the scoring system. And I think as a department, what we thought might be beneficial is if you're asked to do this, is to go in pairs. So you've got kind of 2 people, because ultimately all of your management is going to be based on that scoring. So it is important that it's documented and it's done to the best of our ability. And again, it's probably something within your departments, it's worth getting out and trying to kind of run a kind of quick kind of 5-minute teaching or a simulation, just so you get familiar with it, because doing it in a very time pressured environment can be very challenging, especially with this kind of age group. So it was identified as a potential stroke. A CT and a CTA was arranged as per the RCPCH guidelines. And then there were lots of challenges encountered with getting that imaging. So I suppose the first one was the radiology, the reluctance from radiology to do a CTA. it was initially a discussion of, well, let's start with a plain CT and then we might do a CTA if the plain CT shows anything. So, and I think when this was kind of reflected upon, I think it was that the radiology registrar just wasn't aware of the paediatric stroke guidance. And with regards to getting the imaging, there was a huge issue with best agents to sedate this child. So this was a 3-year-old child who was alert, he wasn't fasted, there were no obvious concerns about his swallow, but we had no idea of what was causing this presentation. And with regards to getting a CT, a plain CT, that was obtained very quickly, but the contrast caused a huge amount of agitation. So he ended up needing ketamine sedation to facilitate that time-critical CT and CTA. Following the CT, he was sent back to the department because the IV access that was cited was not big enough for the contrast. So they wanted a larger cannula in a bigger vein. So again, these are really kind of small things, but again, all these little things caused a delay in this young boy's treatment. So as part of this, in the UHW stroke protocol, it's actually documented in the protocol kind of size of cannula, antecubital fossa, anticipating the need that these children need contrast and to try and avoid any delays in future cases. And then the issue of reporting the images. It was a Sunday afternoon, and at UHW, often the radiology registrar does the first report, but these images needed a consultant report and in a very timely fashion. So we was trying to expedite all of those things whilst trying to care for the young boy and his family, who had, you know, understandably a lot of questions. So learning point 3, have an agreed local pathway for sedation for CT in these patients. I think when you follow the RCPCH poster, there's an assumption that these children will present with a kind of an obvious hemiparesis. They might have an altered level of consciousness and be intubated, but we know that children will present with these more subtle findings, and that you need to kind of nearly preempt as a department if we need to, you know, get a 3.5-year-old through the CT scanner within an hour of presentation, how are we going to expedite that, and to have an agreement locally on what sedation you would be happy to use. We've subsequently agreed on ketamine sedation in our department. Apologies, this CT doesn't really project that well, but I think this was the young boy's first CT, which was a non-contrast CT, and even without the CTA, I think you can appreciate that area of hyperdensity over the right parietal area. It was reported as an area of hyperdensity with some evidence of edema in both the parietal and frontal lobes, consistent with ischemia. The subsequent CTA confirmed a thrombotic occlusion at the M1 segment of the right MCA. And the question was raised whether this child was a candidate for clot retrieval. With regards to interventional radiology, this is what is mentioned in the RCPCH guidance. So when we think, we reflect back to our young boy, again, his scoring, he was scoring a 4, possibly a 5, depending on how that upper limb weakness was interpreted. But so certainly he didn't have a score of over 6. But he was discussed by the interventional radiology services in Bristol, and they had never had to perform this on such a young child, and they felt they didn't have the equipment. So even though it was explored, he was deemed not to be a candidate for clot retrieval. So I think this was the other learning point. This child took a lot of resources, and we were fortunate that our paediatric neurology consultant took on the responsibility of liaising with interventional radiology in Bristol, with stroke specialists in Bristol, with local colleagues in Cardiff, and with the neuroradiology, both locally and in Bristol Children's. So just that we kind of had thought about all these things that allowed us to kind of be able to deliver clinical care to this child. So the decision to thrombolyse, by the time all this was done, he was now 6.5 hours post the onset of his symptoms. So that kind of first facial droop that was noticed by the parents. The CTA confirms an ischemic stroke. Do you want to thrombolyse him? I don't know if people have a... I'll open it to the floor.
Not sure about
I'd have no idea about this. I'm
not sure about
advice.
Sorry, I
He's
missed
a bit
that.
late, isn't he?
Yeah. So I think it's that. So what kind of, you know, the guidelines? What kind of time frame do they suggest?
I thought
Or
it
what
was
is the guideline?
Isn't it within a 4-hour mark?
Yeah, 4.5 hours, isn't it? So I think by the time he presented to the department, he was at kind of 3 hours, and trying to kind of expedite, you know, got seen, got imaging, got sedation, got ketamine. Time was just ticking on, and he was at that 3.5 hour timeline by the time he had that CTA. So I think the decision to thrombolyse was really difficult. And again, when, you know, I think somebody mentioned the kind of, he's too late, and that certainly the guidance is within 4.5 hours, which he was definitely outside of that 4.5 hours. The thing about paediatric stroke is that we haven't really got any randomized controlled studies, and all of the recommendations that we've got with regards to paediatric stroke are extrapolated from adult data, and the RCPCH guideline is actually more of a Delphi consensus method, where a panel of experts have kind of deemed what's acceptable. So the criteria for thrombolysis, you need to have an acute focal neurological deficit consistent with arterial ischemia. You need to have a PEDS NIHSS score of equal to 4 or less than 24. The treatment must be administered within 4.5 hours, and you must have excluded intracranial hemorrhage. So I think, you know, as somebody mentioned, it's the timeline that's concerning. So there was an urgent MDT with kind of the neurologist, both locally and in Bristol, and some interventional radiologists and stroke specialists. And they reviewed all of this young boy's imaging and his neurology, and thought actually this family should be offered thrombolysis, even though he was outside of the window, so outside of protocol window. So with regards to kind of, decisions, again, this guideline, it is a guideline, but it was your kind of your local resources. And I think this case highlighted, you know, how, you know, an expert of a panel of experts decided, actually, based on this young boy's presentation, his neurology, and his very impressive CT findings, that he should be offered the treatment. So with regards to thrombolysis, I'm not sure how many here have administered thrombolysis in a child of this age. I certainly hadn't before this case. It's a really unfamiliar drug in paediatric practice. I think if you do kind of adult medicine, you're very kind of maybe more comfortable with thrombolysis as a treatment option, both, you know, both for possibly pulmonary embolism and stroke. But again, there's a lot of unfamiliarity with regards to this drug in paediatric practice, and again, where it should be given. So as a drug, it can be given within the emergency, within the within a paediatric ward or within a high dependency environment. You obviously need to be aware of contraindications, and I won't go into those because those are all kind of listed in the RCPCH guidance, and you can find some more on the inclusion-exclusion criteria of that TIPS trial. But certainly it's not a drug that we give on a regular basis. So we kind of from CT, we decided that this child should go straight to high dependency, which had already, whilst the CT was happening, had drawn up the thrombolysis, had got the protocol ready. So as soon as the child arrived in the high dependency area, we were able just to give that thrombolysis without any delay. On kind of this case has kind of generated a lot of kind of reflection on our local practice and kind of possibly changing guidelines. And this is what is actually included in our paediatric brain attack guideline, so paediatric stroke guideline. And you might be familiar with this kind of SNAP protocol, has something very similar, but it's trying to minimize the risk of any drug errors. So it's a kind of table, whereas you weigh the child and then it kind of gives you what you should be given over what time scale. And then there's a time, you document the time, what's given and when. So again, to try and minimize any delays in giving medication. And like I said, the TPA can be given within the emergency department, within a paediatric ward. However, post thrombolysis, they do need higher level of care than can probably be offered on a general paediatric ward. So it's very important to anticipate this. So, you know, they need frequent blood sampling, they need close neurological observations every 15 minutes for the first 4 hours, and then every 30 minutes for the next 2 hours. Again, there needs to be a high index of suspicion for anything suggestive of raised intracranial pressure or bleeding. And again, this is so when you're kind of seeing these patients and thinking about thrombolysis, think about their ultimate disposition and whether your local paediatric ward or your emergency department can offer this level of post-thrombolysis care. So that's why we elected to, and we were fortunate that we did have a high dependency bed available when this child arrived. The guideline also kind of mentions kind of treatment of potential complications of thrombolysis. So again, you know, we can give the thrombolysis, but then it's anticipating complications. And the main ones are kind of hypertension and anaphylaxis. So it's just to be aware, like I said, for people doing paediatric emergency medicine, this is quite an unfamiliar drug. So just to be aware of potential complications. So kind of learning point 6 was kind of thrombolysis. Think about, you know, whether you should be giving it, and if you are giving it, where that's given locally and post-thrombolysis care. But before any of this can happen, you need to consent the parents. And again, if you do kind of adult medicine or have been part of kind of stroke calls, you might be very familiar with kind of consenting people for TPA, but lots of people won't be confident and won't be familiar with consenting for TPA, especially within the paediatric population, especially outside of that protocol window. So think about who should be doing that consent process. And it might be locally your neurologist, and whether that's on face-to-face, on a loudspeaker. You know, it depends. Parents might have a lot of questions about this, and questions that might be beyond your scope of expertise. Again, kind of this is a kind of local protocol, and I've had permission from Dr. Saxena, who's our paediatric neurologist who wrote this protocol, to share this. But it's nearly like a standardized patient information sheet that they are given, and it highlights 4 of the main risks that's associated with thrombolysis. One of those is that there might not be any benefit gained from the treatment. There is a potential risk of serious bleeding, allergic reaction, like we mentioned, the risk of anaphylaxis, and the risk of cerebral edema. Okay, So again, think about your local environment, and if you had to give this, would you be confident consenting? Who should be doing that consent acutely? And again, this is something that could be kind of taught or kind of run as a short sim within your department, just to get people familiar with the process. So again, with regards, this is the final learning point. So consent, have a plan. And that might depend again on your local resources. So I've kind of whizzed through that a little bit, but there might be time for questions. So kind of take home points. I think I've reflected a lot on this case. It was a challenging case for lots of reasons. You're trying to deliver clinical care. You're trying to be transparent with the patient. It's an unfamiliar paediatric presentation where you haven't got a huge body of evidence behind you. But I think what it does highlight, it's like everything in emergency medicine, stroke, management of stroke is definitely a team sport, and draw on your local resources, on your expertise locally, wherever that might be. I don't think you can underemphasize the importance of education. So education of nursing staff, medical staff, to be aware of the potential kind of paediatric stroke calls. With regards to education, being familiar with that PED NIHSS scoring and doing that on a regular basis. There is a training that you can do online that is more focused towards adult medicine. It's available on Blue Cloud, but if you kind of Google Blue Cloud and NIHSS scoring, you can do an online learning and put that in your portfolios, just so you've got kind of some structure to how you would approach it. And again, this would be amenable to kind of local teaching and simulation teaching. Think about sedation, especially for CTA. We're all familiar with getting children through the CT scanner just for a plain CT. But again, the sensation of giving that contrast for children is really distressing. And it was really distressing for this young boy. I think he definitely had that kind of feeling he needed to urinate initially and just would not tolerate it, and anticipate the need for a big cannula, the need for contrast when you see these first of all. It might be worth thinking about your local stroke pathway and how you would use your local resources. I know in adult medicine, there's a stroke call. Should there be a paediatric stroke call? It's certainly something we've discussed locally. And think about consent and your level of comfort with consenting these children. And it might be that that is better deferred to a paediatric neurologist, even if that's on speakerphone or over the phone, especially if parents have got a lot of questions that you might not feel you're capable to answer. So that's a little bit of a kind of whistle-stop tour of paediatric stroke. I'm more than happy to answer any questions, and I'll stop sharing.
Hi, Sarah.
Hi.
Thank you so much for that talk. It was absolutely fantastic. And I've definitely taken away lots of those learning points. And yeah, I'll definitely have a little reflection on those. Hopefully I'll never need them. But yeah, it was a really difficult case. I'm going to open it up to the floor. I think there's a couple of questions in the chat, if anyone else wants to put their hands up. So just looking in the chat, the first question that I've got is, how did the 3-year-old in your case do with a thrombolysis? Was there any improvement in their neurology? What was the outcome?
Yeah. I followed this child up quite closely, and even though on the CT scans there was very minimal change, that thrombus was still there, and he's booked for an MRI, I think, in the next few weeks. But certainly from a clinical perspective, when I went up to the high dependency unit to see him, he was chatting, which he wasn't doing at the time. Whether that was, time, or whether that was thrombolysis is very hard to unpick them. But certainly, his speech had returned.
Oh, that's really nice to hear. Thank you. I'm going to see what other questions that I've got. So they're saying, would we be willing to share our guidelines that we have for Cardiff and Vale? I guess I can leave that with you to have that discussion.
And I've already preempted that question actually. So yeah, so this is very much a guideline that was written by the paediatric neurologist, and then this case happened, and there was just lots of important learning and things that I suppose practical aspects of the practicalities of getting children through a CT scan in a timely fashion. What information is given to parents? Where do these children go post thrombolysis? None of those had really been explored. So Dr. Saxena is very happy to share any guidance and would be amenable to other centres trialling the guideline, is what he said. So yeah, I'm happy to kind of leave my details, and then we can maybe get more of a comprehensive review of the guideline.
Yeah, fantastic. Yeah, Sarah, we'll sort out the logistics of that later, but thank you very much. I'm going to ask, I don't think I've got any hands up. Is there anyone else that's got any other questions? I think we had a discussion, you obviously covered quite comprehensively about thrombolysis. Was there ever discussion about whether a thrombectomy would be considered in a child, or was that discussion not really undertaken?
Yeah, so it was undertaken just because of the size of the thrombus. And I think this, I don't want to quote this, but I think this might be the youngest child in the UK to be thrombolyzed. And when it was discussed with Bristol, they certainly didn't, they had never done a procedure on such a young child. And actually it came down to the size of the equipment, that they didn't have the size catheters to be able to offer that. And I think when they thought about transferring this child and the time to puncture time, we were probably looking at kind of in excess of 8 hours. So it was discussed with interventional radiology in Bristol, but based on age, weight, equipment, and time to puncture, it was deemed not in his best interest.
Yeah, and then I think I've got a question. Abdul, have you got your hand up?
Hi everyone, thank you Sarah for this interesting talk, as usual. Just quick question, how would you be your approached in some other age group like adolescent? We know there's a lot of functional symptoms. Some of them might be very able to mimic stroke fantastically. So
yeah.
How you balance things between like over investigating and not missing stroke and contacting family as well?
Yeah, no, yeah, it's if I had the answer to that, I would be a very rich woman, I'm sure. Yeah, it is really difficult, isn't it? And I think we had one a few days ago with a very kind of dense Todd's paresis. And again, these are really difficult and it's only time and reflection and in the presence of a normal kind of CT scan that you probably can confidently say it's not. We know that there are so many stroke mimics out there, but now with the emphasis on thinking about paediatric stroke, I think you're committing yourself to think about it and nearly excluding it unless you're very happy you've got an alternative diagnosis.
Great, thank you.
So Sarah, thank you. Sorry, I've been grilling you. I'm going to give you one last question,
No,
and
it's
then
fine.
we're going to stop
I
for a
can't
break.
promise I'll be able to answer them all, but yeah.
So the last question, so actually it comes from Reese. So sorry, Owen. For those in DGHs without a direct on-call neurologist, who would you suggest would be the best person to consent in this time for the critical diagnosis? So if you're in a DGH rather than where you are in tertiary, who would you be contacting?
Yeah, and that's a really good question. I think with regards, just thinking about kind of Wales, I suppose, because I work in Wales, there's a plan to roll this stroke pathway out for all Wales. So I think we are going to be in this situation where you've got kind of smaller DGHs ringing for advice. But I think, in the context that you've got, I think the review they've done of paediatric stroke is that most of the thrombolysis is actually done by emergency physicians. And by the time they've gone to the paediatric ward. So I think it's kind of upskilling kind of staff to think about stroke. And again, it probably would be, if I think this child is slightly unusual in that he was so young. But I think if you had an older child who was, say, 10, that you were confident with your neurological examination, you've got him through the CT scanner in a timely fashion, and he's got an ischemic stroke. I think you backed up by the RCPCH to be able to consent that patient confidently, you know, and I suppose the consent in itself is not that much different to the consent you give for thrombolysis in stroke in a DGH, or for kind of, you know, massive PE. You know, the consent, what you're consenting them for is very similar. So yeah, I think it's basically not delaying it. So that would be the take home. So not to delay it. And if you're happy to consent and that you've got a child with consistent neurology, with a CT that's consistent with that neurology, I think, and you so within your skills, I think you kind of consent them, and yeah, and liaise with kind of tertiary like neurologists at the same time if you've got the benefit of a team. I think it's definitely, you can never have too many people. So I'd probably have somebody calling the tertiary neurologist whilst I was consenting the parents, probably.
Hi, Sarah, that was great. Sorry, a really difficult one to end you on. But yeah, thank you.
It's a really difficult case, and you know, and again, you know, this is like based on this case and my reflection with the local neurologists. You know, it's not to say what we did was right. I just thought there was so much learning. And I thought it would be beneficial for a group of senior trainees to kind of reflect on, if this child presented to their department, what would they do? Because they often don't present with a low GCS and they're intubated pre-hospitally, and you can just get them through the CT scanner. They're often, you know, really subtle and they can be easily missed. So it's just to put it at the forefront of your mind to think about stroke.
Yeah, thank you. And I think that's the whole idea of today, really, is to try and share those cases that we do all see around the country, but are very rare, and try to share those cases and learning points. So yeah, absolutely fantastic. Thanks. I think Hannah's just put a note, but Sarah, you're off the hook. We're going to take a break now. So thank you so much.
Right.
For that, Sarah.
Thank you. Have a great day.
Thank you.